वेलकम बैक टू रेडियोलॉजी डिकोडेड। आज हम बात करेंगे बेरियम सॉल्व के बारे में। इसमें पेशेंट प्रिपरेशन से शुरू करके पूरा प्रोसीड्यूर, फिल्मिंग एंड पूरा कंप्लीट टॉपिक वाइज बात करेंगे। चलिए स्टार्ट करते हैं। बेरियम सॉल्व इज ए फ्लूरोस्कोपिक एग्जामिनेशन primarily performed to evaluate the pharynx and esophagus। ये एक फ्लूरोस्कोपी प्रोसीडियर है जिसमें फेरिंग्स और इसोफेगस देखने के लिए किया जाता है। एग्जामिनेशन बिगिंस बाय कंफर्मिंग द पेशेंट्स आइडेंटिटी, इंडिकेशन, एलर्जी हिस्ट्री, प्रेगनेंसी स्टेटस। ये टेस्ट करने से पहले पेशेंट का आइडेंटिटी, इंडिकेशन क्या है, एलर्जी की हिस्ट्री है क्या नहीं, या प्रेगनेंसी स्टेटस पूछना चाहिए। द पेशेंट शुड आइडियली remain NP or nil per mouth or nil per oral for 6 to 8 hours before examination। ये प्रोसीड्यूर करने से पहले 6 से 8 घंटा पेशेंट को खाली पेट रहना चाहिए। स्मोकिंग, च्यूइंग गम, ड्रिंकिंग वाटर शुड बी अवॉइडेड बिफोर द स्टडी एज दे स्टिमुलेट swallowing। Dentures, necklace, metallic object around the neck and chest must be removed before imaging to overcome any unnecessary artifact। A preliminary scout radiograph may be obtained to detect calcification, foreign bodies, abnormal gas pattern, etc. Next, the fluoroscopy unit should be checked for image quality, radiation protection, proper collimation before starting। High density barium sulfate suspension is commonly used for mucosal assessment। Low density barium is preferred when evaluating esophageal motility and transit। Water soluble iodinated contrast is used instead of barium if perforation is suspected। परफोरेशन के लिए बेरियम की जगह में वाटर सोल्यूबल आयोडीनेटेड कॉन्ट्रास्ट यूज़ किया जाता है। The examination usually starts with the patient in the upright position। The patient is instructed to hold the barium in the mouth until told to swallow। Continuous fluoroscopy begins just before the patient swallows to capture the entire swallowing sequence। Continuous fluoroscopy और मॉडर्न फ्लोरोस्कोपी मशीन में सीने इमेजिंग लिया जाता है पूरा swallowing process को कैप्चर करने के लिए। The oral phase of swallowing is brief and is generally not the primary focus of the standard barium swallow। The pharyngeal phase is evaluated for aspiration, residue and coordination। The upper esophageal sphincter should open completely during swallow without delay। The cervical esophagus is examined in AP and lateral projection for structural abnormality। Rapid image acquisition is essential because the contrast passes through the pharynx in less than 1 second। Spot radiographs are obtained during fluoroscopy to document significant findings। Radiation exposure should follow the LRA principle by minimizing fluoroscopy time and using tight collimation। Right anterior oblique 35 to 40 degree is preferred position because it projects the esophagus between the vertebral column and the heart। The AP projection is mainly used for evaluating cervical esophagus and pharynx। A true lateral view is valuable for detecting aspiration and posterior and phalangeal abnormalities। During fluoroscopy, the radiologist follow the contrast continuously from the pharynx to gastroesophageal junction। बेरियम सॉल्व के लिए हम फेरिंग्स से लेकर जी जंक्शन तक एग्जामिन किया जाता है। नॉर्मल प्राइमरी पेरिस्टल्सिस begins immediately after swallowing। Secondary peristalsis is initiated by residual food or barium distending the esophagus। Failure of the secondary peristalsis may indicate an esophageal motility disorder। Failure of secondary peristalsis may indicate an esophageal motility disorder। The normal adult esophagus measures approximately 25 cm from the upper esophageal sphincter to gastroesophageal junction. नॉर्मल इसोफेजियस का लेंथ होता है 25 सेंटीमीटर, जो स्टार्ट होता है इसोफेजियल स्फिंक्टर से लेकर पूरा जी जंक्शन तक. द इसोफेगस हैज 3 and normal anatomical constriction visible during contrast examination. The first constriction is at the cricopharyngeus at the level of C6 level. Second constriction occurs when where the aortic arch crosses the esophagus. Third constriction is produced by the left main bronchus before the esophagus passes through the diaphragm. Next, the esophagus hiatus is located at the T10 vertebral level. The gastroesophageal junction normally lies just below the diaphragm. Z line marks the transition from squamous esophageal mucosa to gastric columnar mucosa. Next, a smooth uninterrupted column of barium indicates normal esophageal transit. Persistent narrowing with proximal dilation suggests obstructive lesion. Delayed emptying with a tapered distal esophagus may indicate achalasia cardia. Delayed emptying with tapered distal esophagus ये achalasia cardia के लिए इंडिकेशन होता है. Barred-Wick appearance on barium swallow is classical sign of achalasia cardia. Corkscrew or rosary braid appearance is a characteristic of diffuse esophageal spasm. An esophageal wave is a thin mucosal membrane most commonly located in cervical esophagus. The combination of esophageal wave, dysphagia, iron deficiency anemia is known as Palmer-Vinson's syndrome. Skatsky ring is a thin mucosal ring located at gastroesophageal junction and commonly causes intermittent dysphagia. Dysphagia means difficulty in swallowing. Dysphagia means difficulty in swallowing. A Jenker's diverticulum is a pulsation diverticulum arising through Killian's dehiscence above the cricopharyngeus muscle. A traction diverticulum usually occurs in the mid-esophagus and is caused by mediastinal inflammatory fibrosis. जो ट्रैक्शन डायवर्टिकुलम होता है वो मिड इसोफेगस में पाया जाता है एंड इट इज कॉज्ड बाय मीडियस्टिनल इन्फ्लेमेटरी फाइब्रोसिस. एपिफ्रेनिक डायवर्टिकुलम ये डेवलप होता है डिस्टल इसोफेगस में एंड एसोसिएटेड विथ इसोफेजियल मोटिलिटी डिसऑर्डर. स्लाइडिंग हाइटल हर्निया type 1 is the most common type of hiatal hernia seen in barium swallow. A paraesophageal rolling hiatal hernia type 2 has a higher risk gastric strangulation than a sliding hernia. So जो hiatus hernia होता है इसका दो टाइप होता है. type 1 means a sliding hiatal hernia, type 2 paraesophageal hiatal hernia. Next, gastroesophageal reflux is demonstrated fluoroscopically by observing the retrograde flow of barium from stomach into esophagus. In normally, the flow of barium is usually from mouth to G junction, but in case of gastroesophageal reflux, we fluoroscopically observe the retrograde means opposite side flow of barium from stomach to esophagus. The reflux may be provoked using Valsalva maneuver, abdominal compression, or Trendelenburg position. Abdominal compression is usually done by raising both legs. Chronic gastroesophageal reflux disease, इसको GERD भी कहा जाता है, is most common cause of benign peptic esophageal stricture. The Barrett esophagus is characterized by replacement of normal squamous epithelium with intestinal type columnar epithelium. Barrett esophagus is a significant pre-malignant condition for esophageal adenocarcinoma. जो Barrett esophagus है ये मैलिग्नेंट के प्री कंडीशन होता है for esophageal adenocarcinoma cases. Benign esophageal strictures typically appears as smooth and symmetric narrowing on barium swallow. Malignant esophageal stricture usually produce irregular shoulder narrowing and mucosal destruction. The classic apple core appearance may be seen in advanced constricting esophageal carcinoma. Apple core's appearance in barium swallow is seen in constricting esophageal carcinoma. Double contrast barium swallow provides superior visualization of small mucosal ulcer, erosion, and early neoplasms. A persistent filling defect on barium swallow suggests a polyp, tumor, foreign body, and impacted food bolus. Extrinsic compression of esophagus may result from an enlarged left atrium, aortic aneurysm, thyroid enlargement, mediastinal mass, etc. etc. When esophageal perforation is suspected, water-soluble iodine contrast media should be used first, and barium should be avoided initially to prevent mediastinal contamination. If barium is perforated in the peritoneal cavity, it became hardens and causes peritonitis. Aspiration during barium swallow is identified when contrast enters the larynx, trachea, and bronchi. A video fluoroscopic swallowing study (VFSS) is the gold standard for evaluating oropharyngeal swallowing disorder. Delayed opening of upper esophageal sphincter (UES) increases the risk of aspiration. Silent aspiration occurs without coughing and is commonly seen in neurological disorder. The cricopharyngeal bar appears as a posterior indentation at the level of C5-C6 due to hypertrophy of cricopharyngeus muscle. Esophageal candidiasis typically produces a saggy esophagus appearance due to multiple plaque-like lesions. Herpes esophagitis usually presents with multiple small superficial ulcer on double contrast study (CMV). Esophagitis characteristically produce large, linear and deep ulcer in immunocompromised patient. These three are related to infection of esophagus. CMV means cytomegalovirus. Next, peel-induced esophagitis most commonly affect the mid-esophagus near the level of aortic arch. Diffuse esophageal spasm produce simultaneous non-propulsive contraction result in corkscrew esophagus. Nutcracker hypercontractile esophagus demonstrate high amplitude peristaltic contraction despite normal propagation. Scleroderma causes a dilated atonic esophagus with absent or marked reduced peristalsis. In scleroderma, an incomplete lower esophageal sphincter or LES predisposes the patient to severe gastroesophageal reflux. Achalasia is characterized by failure of lower esophageal sphincter relaxation and absence of normal peristalsis. Long-standing achalasia increases the risk of esophageal squamous carcinoma or esophageal SCC. Esophageal varices appears as multiple serpiginous filling defect caused by dilated submucosal vein. Portal hypertension is the most common underlying cause of esophageal varices. Foreign bodies lost in the esophagus are most frequently located at the three physiological constriction during fluoroscopy. टाइट कॉलिमेशन पल्स फ्लूरोस्कोपी पोस्ट लास्ट इमेज होल्ड जिसको बोलता है ALIH टू रिड्यूस मल्टीपल फ्लूरोस्कोपिक एक्सपोजर वी यूज लास्ट इमेज होल्ड. This protocol should be used to minimize radiation dose after completion of the examination. The patient should be advised to drink plenty of fluid as white color stool for 40 24 to 70 hours are a normal finding after barium ingestion. This is the aftercare for barium swallow. The principal indication for barium swallow is the evaluation of dysphagia or difficulty in swallowing. Other common indication includes odynophagia, GERD or gastroesophageal reflux disease, suspected stricture, diverticulum, achalasia, and esophageal lesions or tumor described previously. Barium swallow primarily evaluates the esophagus, whereas barium meal evaluates the stomach and duodenum. जो बेरियम swallow होता है वो होता है esophagus के लिए, and barium meal होता है stomach and duodenum और small intestine के लिए. The patient should be instructed not to bleach during double contrast study, as this can degrade mucosal coating. The effervescent granules are administered बिफोर बेरियम इन द डबल कॉन्ट्रास्ट स्टडी. डबल कॉन्ट्रास्ट स्टडी के लिए बेरियम के साथ इफरवेसेंट ग्रेन्यूल्स दिया जाता है टू प्रोड्यूस गैस्ट्रिक डिस्टेंशन. एडिक्वेट म्यूकोसल कोटिंग इज एसेंशियल फॉर डिटेक्टिंग सब्टल अल्सर, इरोशन एंड अर्ली कार्सिनोमा. एक्सेसिव रेसिडुअल सलाइवा और म्यूकस may reduce barium adherence and decrease image quality. Proper timing of spot radiograph is critical because the barium column passes rapidly through the esophagus. Continuous communication between radiologist and patient ensure optimal image acquisition during swallowing. The examination should be terminated immediately if patient develops severe aspiration or respiratory distress. Suspected esophageal perforation is the most important contraindication for using barium sulfate as initial contrast agent. Water-soluble iodinated contrast is the preferred first-line contrast medium when perforation or anastomotic leak is suspected. Barium leakage into the mediastinum or pleural cavity can produce severe foreign body inflammatory reaction. Fluoroscopy time should always be kept as short as possible, as reasonably achievable. Use of pulse fluoroscopy significantly reduces patient radiation exposure without compromising diagnostic quality. Gonadal shield is generally not recommended if it obscures the area of clinical interest. The radiographer should use appropriate personal protective equipment, including lead apron, thyroid shield during fluoroscopy. The final report should document esophageal motility, mucosal pattern, luminal caliber, filling defect, reflux, stricture, diverticulum, etc. A normal barium swallow demonstrates smooth mucosal fold, coordinated peristalsis, rapid contrast transit, and no reflux or filling defect. Barium swallow remains one of the best dynamic fluoroscopy examination for assessing both structural and functional abnormalities of esophagus.